Hello.
Hello, hello.
All right, let's regroup and welcome our next set of speakers. Floor is yours.
Good morning, everyone. You guys didn't wake up yet. Good morning, everyone. Oh, I love when you guys wake up. My name is Andrea Dalzell. I am affectionately known as the seated nurse. I am next to...
I am Dr. Sabrina Jamal-Eddine. Yep.
You can hype that up a little bit.
Yeah, that's me.
You can hype that up.
I am a health humanities nurse scientist.
Okay, and obviously we are missing our third name up there, but that's okay because she's here with us in spirit.
Yeah, she is.
And we're going to pay some homage to her because without Dr. Ana Valdez, we would not be sitting in front of you this morning. So we are grateful that she brought us in for this panel, and though we are running it ourselves, she very much has us in an alignment. So I'm going to ask 3 questions of you guys this morning. The first one being, when did you understand disability? That is a loaded question. When did you understand disability? Because now I'm going to ask you, when were you first introduced to it? Was it through a grandparent? Was it through your own health issues? Was it through a child? Was it through a peer? Think to when you were first introduced to it, because that has a lot to do with how we're going to be able to portray our information today. Because you have to understand when you first been introduced to it, and then when you first understood it, and if you actually understand it today. And with that, I'm going to turn it over to Sabrina.
All right. Hello, can you hear me? Okay. All right, so we are going to start with spoken word, which I mentioned yesterday. So this is actually Andrea's first time hearing this one. But this is a poem on my experience with disability, and specifically with ableism. So it talks about, so my disability was manufactured or produced within a medical context, and I talk about that experience and process. So yeah, in the spirit of art, we are gonna start with that. So this is a poem on ableism and hidden disability. If you are familiar with spoken word, usually within a slam setting, it's really like call and response. It's rooted in Black American ancient oral traditions. And yeah, that's what I did my dissertation on. So, all right. To the man who approached me after I parked in my accessible spot, hatred painted your face with transparency so I could see your every thought. She ain't blind, she can hear just fine. Doesn't look like demons have incapacitated her mind. She can walk in her body, looks pretty aligned. She's clearly not handicapped, so who does she think she is parking in that spot? He thought, looks like a lesson, needs to be taught. He got a cousin in a wheelchair, so this must have really got him distraught. Finally, an opportunity to show some resistance like a white man's first boycott. You felt so inclined to speak on behalf of the divine and all of mankind, to tell me that I am disgusting and that I should save that spot for somebody who actually needs it. Thank you, sir. Oh, thank you. Thank you for making me feel like a piece of shit, so much so that when I got home that day, I couldn't help it but sit and cry to my mother, regretting that I did not lift up my shirt to show him the mural of scars that the surgeon had painted on my skin, regretting that I did not force that man to listen to my story. To hear my allegory about how a doctor in a white coat said the only way to fix the achiness from the curvature in my back would be to realign my spine like a medical carpenter, with my body being the furniture. The words of the surgeon had been cultivated with precision like a lying politician with a charismatic audition. 3 1-inch turned into 3 5-inch incisions. The minimally invasive technique that the surgeon said would have me up and walking around the mall in 3 weeks left me paralyzed in bed for 3 3 months, 3-hour surgery, lasted 6, 2-day stay, turned into 7 with 36 pills a day, morphine shot up my vein every 8 minutes, couldn't even take away an ounce of the pain, like the inefficacy of shooting up cocaine, blood sucked out my body like a vampire through a JP drain, had a 2-liter blood transfusion, inebriating my body with a stranger's thick red liquid like Cabernet. I wish that man could have heard how 16 years of my life had passed, but it was not until my nurses removed the bandages, unmummified where I was crucified, that I ever saw my dad cry. I woke up from the anesthesia on a midazolam high, asking why does it hurt to breathe? Lie after lie had escaped through the crevices between that surgeon's teeth. In literature, it's called sarcasm when you say the opposite of what you mean. Hyperbole, it's a form of verbal irony like the smell of blood that intoxicated my nose. Tyranny, my body became a casualty of a capitalistic society. My lungs became incarcerated behind the 2 titanium rods and 18 screws that now line my spine. They became the bars of my body's jail cell where every breath, even shallow ones, felt like someone was using a knife to scrape out my flesh. I wish I knew how it would feel to be free. I wish I could break all the chains holding me. I wish I could say all the things that I should say. Say 'em loud, say 'em clear for the whole round world to hear. I wish that man could have heard how 6 months after my surgery, over 500 lawsuits broke out against the surgeon, revealing that he had been purposefully messing up patients' backs, performing double to triple the amount of surgeries, attaining big-ass money stacks, funding mansions with private cul-de-sacs and Cadillacs, and hospitals were silent because, man, oh man, did they love those kickbacks, sit back like they're watching their favorite quarterback while they throw back a six-pack. But house arrest gave the surgeon a panic attack, so he fled the country on a private jet to save his own ass. I didn't even have a lawsuit. I just wanted to be able to breathe. I remember after each appointment, I'd sit in the car with my mom and scream, tears flooding like the Red Sea. God, how could you do this to me? I've never been religious, but desperation got me down on my knees to pray and plead. I couldn't quite see how this could happen merely because someone was greedy, thirsty for money, and the manifestation is man-made disability. In summary, I took a year off to get a revision surgery, had everything taken out and put back in properly, and the minute that I got out, it no longer hurt to breathe, unincarcerated underneath, but still suffocated by society's misperception of non-apparent disability whenever that part of me sneaks into the realm of visibility based on the services I still need. I just hope you listen before you judge the pain that you can't see and understand that conversation about identity is a much more effective means of getting answers than trying to see the unseen. I wish I could share all the love that's in my heart. Remove all the bars that keep us apart. Yeah, I wish you could know what it means to be me. Then you'll see and agree that every man should be free.
Take it in, right? I don't know how I'm going to be able to keep speaking up here because, I think you wrapped it all up. But I think those questions that I asked at the beginning of this, I hope that caused you for some more thought process throughout that spoken word just now. So we're definitely going to have another one for you. But I hope that it gets you thinking because in this room, we're all nurses, right? I think so. Yeah, no, we're not? No? And nurse lovers and everyone else in between. We love y'all too, okay? But at the end of the day, this is a room where we get to say to each other, one, disability is not an impossibility, okay? It can happen to any one of us at any point in time. And that is a given. We know that. We can even age into disability. Now, on the flip side of that, we also take care of those with disabilities, whether they claim it's a disability or not, whether they acknowledge it themselves or not. The moment that they're in our care, there is something that is being cared for, which can be considered a disability. So now, listening to us in our own advocacy, we're going to open up to some who we are and what we're about. So like I said to you guys before, my name is Andrea, and I am affectionately known as the seated nurse. Do I love this term? No. But why do I use this term? Because I am the first registered nurse to go through nursing school using a wheelchair in New York State. I passed my boards in 2018. So, thank you, that is definitely a feat, but let's not stop there. After nursing school, and we all know the struggle of nursing school, after nursing school, I went through 76 rejection interviews, trying to land clinical position, because my goal was to become a CRNA. I wanted that more than I wanted anything else in the world. Why? Because I had already gone through 35 surgeries. I have seen a vast of nurses, okay? So we're going from the OR, the EDs, med-surg, ICU, step-down units, home care. Anything that you thought a nurse was gonna be in, I probably saw them at least 17 times in my life. Not one of them used a wheelchair. Not one of them used a walker. Not one of them had some type of amputation. Not one of them had some types of dexterity issues, or at least nothing that was apparent to me, and I was rolling circles around nurses all the time. Okay, so when you are in front of these caretakers and you're trying to say representation matters and I'm not seeing anything, and then to go through nursing school and sit through 76 rejection emails saying that no, you're not welcome, when my peers are getting hired left and right, recommending me to go to this place they're hiring, and then getting the rejection that they will not hire me because of my wheels, because my apparent disability has already put out a bias to say you are not welcome. Because somewhere down the line, disability now is synonymous with unhealthy. Disability somewhere down the line is synonymous with not being able, and it's then gonna lead to questions. How do you do CPR? How do you ambulate a patient? How do you do X, Y, and Z in a clinical setting? Did you guys forget that there are accommodations for everyone? I'm pretty sure we know nurses that roll around on their chair the whole time. I know nurses that don't even want to run to a code. I know nurses that will, to hide, they will hide in the broom closet just to not be at a code. But you're worried about my wheels not being able to make it fast enough to a code when I can roll circles around people. But that's because I grew up with my disability. I was put in a wheelchair at the age of 12 years old. So not only did I go through puberty and dealing with adolescents bullying me, I did it in nursing school, and then I did it again through interviews just to prove a point. My chance came during the peak of COVID in New York City when the governor asked for nurses to come out of retirement to help. That's when I get to call up HR and say, I'm a nurse, and they're like, please come in tomorrow night. And I show up, and I pass HR, and I pass all the nurse managers, because everybody's just like, get to a floor and help out. And then I get to a floor, and the nurse manager is instantly like, I don't think you belong here. You're an infection control risk. We do not believe that you can do this job or do it at a way that we can do it. I was like, what, standing? Walking around? What is the real comparison here? And I was like, you know what, I got through HR. If you have an issue, go back to HR. That same night on that unit, we got our first vented patient, and the nurses knew nothing because they were ortho nurses. I was the only one with outside experience that had vent knowledge because respiratory therapy was tied up in the ICU. As soon as they found out I had vent knowledge, I was shipped to the ICU for 6 months. I worked ICU COVID from a chair, and I was the only one in the nation to do it, and that's what gained national news. Can I get a job today in any regular facility? Probably not, unless anyone wants to hire me. Probably not, but that is simply because I now have a social media presence, and hospitals don't like that either. So I went through 76 interviews to prove a point, proved a point during the peak, and now trying to prove a point to a room full of my peers, letting them know that disability does not define anything. It is just a barrier. because society did not open the doors for people like me or those with invisible disabilities. So with that, I'll pass that over to Sabrina.
Yeah. Well, let's see. Yeah. I think this brings up a lot of like the differences that we experience in terms of apparent versus non-apparent disability. So if you have an apparent disability, like there's a lot more barriers up front. And then I have the experience of having a non-apparent disability where like people don't view me as a disabled person, and then it's a coming out process, but it's a shared experience with like constantly proving yourself. Like that was so much in your narrative. It's just like a nonstop, like we have to prove ourselves in every situation that non-disabled people who also, there's non-disabled people also experience barriers and are not perfect. Providers are not forced to prove themselves the same way, and that takes a toll on your body to just constantly be mistrusted, viewed as a liability, and forced to prove yourself. But yeah, so I told my story about my disability, so I have a connective tissue disorder, and then I also acquired that disability when I was 16, and that, like Andrea was saying, like we have so much experience from being medicalized, so disability is medicalized. It's something that is placed under the jurisdiction of medicine, so doctors and nurses become the gatekeepers of disability, who has access to services, like social services and everything that we need. So the fact that disability is so absent from the content that we're taught within nursing school. Like, I don't know about you, but I went through my BSN program and I probably heard the word disability like 3 times in passing, which is like wild because Andrea mentioned like everyone in an acute setting is experiencing at least temporary disability. So the fact that there's no education on ableism, which is so inextricable from racism, is just like wild. But yeah.
I don't know what else to say after that part. Like, I mean, it really is, because no matter which way we go with this, whether I'm in a clinical setting, acute care setting, whether I'm in an educational setting, disability is always something that someone has to fight for, right? And then in the other conversation to that is we have to be forthcoming with our disability. And in a room full of nurses and nurse lovers, right, we understand that that's protected under HIPAA. I don't have to say anything about my disability. However, those of you in the room can possibly say to me, well, you have to tell me about your disability in order for me to provide accommodation. Why can't you just see something as a barrier, and that barrier is preventing me from showing up as my full self? And if I am presented with that barrier, then I'm sure other people are presented with that same barrier and do not know how to actually communicate that without disclosing a disability that they may not feel comfortable disclosing. Right? And when you look at what even opens the door to nursing, right? Because all of us can be considered a gatekeeper at some point, depending on how we say no or yes. And if we're saying no from the very inception based on perception or based on how someone is presenting as a barrier to what they need, then how do we allow for people to show up as their full selves? And now then, how does that transfer into our patient care at the end of it all? Because if someone is temporarily disabled or going to be permanently disabled and their whole life has now changed, how do we show up for them? Because they're not going to be able to show up for their true selves if we're already putting out a bias.
Yeah, they ask us to come forward about the disability, but fail to address the ableism. Like, how are we supposed to come out when we know we've experienced like pushback from people, and we hear the ableism nonstop? It's like it's nonstop. So yeah, you can't expect students to disclose disability if you don't put the work in to create an environment that is safe for them. And a lot of it has to do with like teachers and professors not, if they've never seen it before, then they are not willing to like imagine what's possible from what they haven't seen. So a lot of it is just about innovating and like being like, I don't know what the solution is, but we're gonna figure it out together. And it takes time and it takes energy and it takes money, but we are entitled to accommodations like anyone in any other job is. So there's this myth that like they'll accommodate for you in school, but what's gonna happen when you go out in the workforce? The workforce is required to accommodate for us too. It's law.
Even more so in education, right? Education, anyone that's receiving federal dollars, okay, means they have to abide by the Rehabilitation Act, the 504 Act. We have to, and that just means that we have to figure out an accommodation. So for those that have students that get told that they're an infection risk, there are doctors that are operating in an OR in a standing wheelchair that go through sterile protocol every day. So that their protocol is already out there, whether you have the evidence-based practice right in front of you or not. And let's also, when you guys are doing research, please put in disability to that, because any race, any gender is accepted to the disability club. We know that. But when we're reading a study, we don't know if someone has been affected by a disability, in which can skew the study. And that's where the problem lies in a lot of our research, is that we have nothing to pull from. All of it is now trying to just create cumulative information from the quantitative information being put out. And none of it is actually flowing through, when we know nurses have the highest workforce injuries in the world, not nation, in the world. Why is this? Because we can never find a Hoyer lift. We could never find that second person for a two-person lift, right? Putting somebody in Trendelenburg to push them up in bed is hard work. We do not learn body mechanics. There's so much to what we don't learn that those that live with disabilities actually know more than anyone else. And when you're talking to someone like me, who I was diagnosed with transverse myelitis at the age of 5, I went through the transition of using a full wheelchair by the age of 12, and I'm 37 today. So I've had 44 surgeries, again, teams of people. I realized that the one thing missing is there's no real collaborative effort on how to actually help someone with a disability through the healthcare system. So whether they're coming into your ED or your clinic, do you even have different sized chairs? Sitting up higher, mid chairs? How about a space in your office for a wheelchair or a walker to actually be without being in the way, without being forced to look at a different direction than other people? Like, these are the things that I ask you about in healthcare, because if someone is supposed to be able to come into healthcare and it be fully accessible, is it really? And universal access is not really universal. That's just a blanket term, but we should have blanket things that should cover for basic needs. Like, everyone can use ramps and not steps, right? And everyone can be able to press a button if it's at a certain height versus being up higher, right? So there's different things that should just automatically be in place in your facilities that we don't even advocate for. So therefore, someone with a disability coming in can't even say that they feel welcome, because there's just basics that are not met.
Yeah, you touched on two really good points. One, you alluded, nursing is a disabling profession. Like, the way that it's currently set up facilitates burnout, which is just exploiting workers. Like, there's not enough money going into the workforce so that patient care loads are manageable, and in terms of like accessibility, like it is disabling. And so the nursing profession has so much to learn from disabled people so that we can prevent the unjust manufacturing of disability. And then, yeah, just in terms of patient care too, if you're accommodating for disabled nurses, you're gonna be building in accessibility for disabled patients as well. Like, there's so much to learn from having disabled people in the nursing workforce, but we're pushed out of like clinical settings especially. So yeah, nursing needs to learn from disabled people.
Okay, so there's a question here that says, how can our colleagues be effective accomplices in pursuing disability justice?
Okay, do you want me to start or you want to start? Okay, all right, so the first important thing is to understand the difference between disability rights and disability justice. You can kind of view it as a framework with the difference between reproductive rights and reproductive justice. One typically serves
white, economically privileged women, for example, with reproductive rights, reproductive justice leaves out multiply marginalized people. Within disability rights and disability justice, specifically within the context of like nursing education, when I did my research on I did a qualitative metasynthesis on ableism in undergrad nursing education, and almost every single study, the disabled people that were in nursing education in these studies were white women. There were very few people of color. Like, if there was a person of color in the study, it was like one. So that has to do with intersectionality. People are experiencing multiple barriers. Like, we experience racism and ableism when we're in the nursing education setting. I've had plenty of times where my white professors, not usually, and patients and preceptors will just say microaggressions. So we're experiencing both of those at the same time, and we can't separate them. So within nursing education and disability rights, they expect you to like file a lawsuit if you experience ableism in nursing education, and who is economically privileged enough to file the lawsuit? Usually not poor people of color. So that's why people are not making it through and are experiencing those multiple barriers. So disability justice focuses on, I mentioned yesterday, it's a movement based in the Bay Area. A lot of times the term is co-opted as just justice, but it's a specific movement that has 10 principles that include like interdependence, cross-movement solidarity, and it's very radical. And so it centers like the marginalization of people who are not often protected by the law. So you can change all the laws and policies in the world, but until you get people to actually be invested in practicing equity for disability, it doesn't matter. So, for example, my best friend is blind, and she experiences, like, there are laws protecting her from housing discrimination. She experiences housing discrimination at every single place she goes to. As soon as she mentions she's blind, they're like, oh, sorry, the place isn't available anymore. Or like, as soon as she discloses that she has a guide dog, like, you can have all these laws and policies here, and people will get around them. We could not get an Uber in Canada because she had a guide dog with her. We got turned away from 4 Ubers. Like, there are laws in Canada protecting us that say we should be able to have a service dog, and these laws aren't being put into practice. We can't file a lawsuit right then and there. You can't depend only on law to have people create change. You need to teach people, like, humans matter, disability matters. We are valuable people. These are not someone just walking around with a pet. So, like, when you focus on disability justice, you're working, especially like within nursing education, it has to do with teaching the professors about the 10 principles of disability justice and having them humanize disabled people and not look at a disabled person and say, you don't belong here. So not just relying on law, like, rights are not going to fix everything. You need to change people as well.
Yes. I mean, that's what drives nursing and the trajectory of nursing. Every time we talk, every single one of you that I've listened to thus far, I mean, this is what we're talking about. We're talking about how do we move the profession forward and how do we keep growing. Well, we can't keep growing without having disability and advocacy being at the forefront of our discussions, because if the door isn't open, who are we opening the door for? Right? And every single one of us are talking about all of these studies and what great things we're doing. But again, if this is centered in patient care, or even for our students to be able to come in behind us, how are we allowing for that door to stay open if we're automatically closing it towards any type of visible or invisible disability? So as you're thinking about how it first showed up in your life, usually it's by a grandparent. A grandparent is usually older in your home or around your home, and then at some point or another, they go from being able to walk around all right and they're shuffling their feet to now using a cane to now maybe being in a wheelchair every once in a while, or not being able to come out of bed anymore. And then you see this rapid decline, and then all of a sudden, death is there, right? It's knocking on the door. And that's what scares us. That's what scares us as nurses. It scares us as healthcare professionals, whether you're in hospice or whether you're labor delivery and you're seeing life come into the world. The two very vast aspects always includes disability at some point, right? And here's where we have to make sure that we're not closing the door from the same care that we're giving. So I love to talk about nurse magic. Nurses have magic, right? We are divine in being able to give someone our care. So if we are meeting them for their first time in the ED and they're going through whatever trauma they're going through, guess who's the first person to talk to that patient? The nurse. They're the ones that are going to go right up to them and say, I am so-and-so, there's a lot of people working around you, but this is my name, this is who I am, and I am looking out for you. That's the first person, right? You wake up from surgery, the first person you're seeing is not the anesthesiologist, not the doctor, it's your PACU nurse. That nurse is going to be right there like, hey, I need you to take some deep breaths for me. I'm right here for you. What is your pain feeling like? Let's check and make sure everything looks good, because it's the nurses that deliver that care. It's nurse magic, right? We're making sure that we can heal you. We're listening to everything. We're using all of our senses. Now that person has a disability. That person is now saying quality of life. What does quality of life look like, right? Quality of life for them is going to change. They've now had a drastic accident. They've had a stroke. Something has happened. Now quality of life is different. Who determines that? Who determines that? You can say it out loud. Whoever you think it is, just throw it out there. Is it the nurses? Is it the family? Is it the doctor? Is it the patient? Who is it? Say it louder. The patient. It is the patient. But how does the patient know that life goes on if there's no representation? Or if the thought process is to say, well, you're never going to be able to do X, Y, or Z again. Because it's the narrative that we put out there. It's the narrative that we portray from the very beginning. And if we continue that narrative, it leaves the hospital with them when they go home to rehab, thinking that they're never going to have the life that they want, okay? Now, are they compliant with meds? Are they compliant with showing up? No, they hate life. Life's over. Life's depressing. Then they finally find a little spark, and they show up and go to school, and let's say they want to go back and give that nursing magic, because they got some and they realized that they made it through whatever they made it through, and now they can handle it, and they want to go to school. And from the moment they get to school, they get a form that says, please fill out your health assessment. Can you stand for 12 hours? Can you lift 60 pounds? Can you do X, Y, and Z? And usually a doctor is the one filling out that form, and they're saying no, new stroke victim, new this, new that. Change the narrative. May not be able to stand for 12 hours, but they can surely sit for 12 hours with no issue. What's the difference between a short nurse and me? I can't use the step ladder. I can just use a gripper. They can use a step ladder, but they're accommodated. The thought process is that if our narratives change, the way that we see our patients change, and the way that nursing really steps into nurse magic and being able to actually cure the world. Because now we're allowing people to see a different side of disability, and it's not just equated with impossible. It's anti-impossible, because we've given that magic back to them.
Yes, to all of that. And that narrative that you're talking about, like, is so well documented in terms of quality of life and healthcare providers viewing that disabled people automatically have no quality of life, that disability is worse than death. Like, there's surveys of healthcare providers that say, if I were to become quadriplegic right now, I would rather die. Like, that's by emergency care providers, EMTs. Like, if those are the people deciding whether or not to save somebody, and they're viewing that disability is worse than death, it's going to impact the quality of care that they're providing to people. It's impacting medical futility decision making. So switching that narrative and working really hard to understand that, like, disability is not worse than death. Human beings are extremely adaptable. Like, people would ask, like, so I had the 24/7 breathing pain for 2.5 years in between those 2 surgeries. I still had, like, yes, I was in a lot of pain. I was still very happy to be alive. My body adapted to it. Like, I learned how to minimize pain. I learned what works. I had to lay on the ground and have someone, like, put their weight on my scapula so I could have a couple minutes of not being in pain. But overall, I'm very happy I was alive for those 2.5 years. And the idea that acquiring disability, because we have these terrible narratives that are fed to us in the media and from birth, that disability is worse than death, it's really hard, and it impacts the psychosocial well-being of disabled people. Like when people who are like just acquiring the disability rapidly, who are not seeing disabled nurses, who are not seeing that disabled people continue their lives and work and lead meaningful lives, just like is really harmful.
Yeah, so now I'm gonna ask, how does ableism directly affect your day-to-day?
Okay, so for me, as ableism shows up a lot within education and workplace for me. So disability is like so inextricably tied. The conceptualization of disability is rooted in the ability to produce work normatively or labor normatively. So for me, it shows up, so I'm registered with the Illinois Department of Rehabilitation Services. They gave me like a whole setup that I have that makes work not painful for me. Like if I don't have my assistive devices, I am in a ton of pain. And so having access to the services is so important, and ableism will show up with professors and advisors, which luckily within my PhD program and now postdoc, like I'm in a disability studies department that understands disability, so for the most part, I don't have to do that fight as much as I used to, but within the BSN program, it was hell. They don't want disabled people there, and that's at every school across the country. It's not isolated to any specific school. So it's that constant fight for accommodations. It's the mistrust of disabled people, especially with non-apparent disability. Like, you can't see what I have. I'm the only one who can tell you what I'm experiencing, and I'm not gonna make something up that I don't need. People don't ask for things that they don't need, and I talk about that in the last spoken word poem that I'm gonna do today. It's just a constant proving and mistrust, and yeah, I'll leave it there.
Any person-to-person interaction can bring up ableism, especially with an invisible illness. But for me, ableism is like paparazzi. Stairs follow me everywhere, paparazzi. I can't go anywhere without needing an elevator. There's another set of paparazzi, right? And I'm always going through a back door, so I must be famous because there's never an entrance at the front door. Now, if you're even thinking about like emergency rooms, unless your emergency room has been built within the last 20 years, ADA access looks very slim in a lot of emergency rooms, right? So even me saying that I want to go and actually take care of my health is ableism, because I need to figure out which hospital system I'll be able to not only go to the ER, but if I get admitted, will they have a bathroom in the room for me that I can get in? That's crazy. I can tell you that if any of you have seen my most recent campaign with Hypothesis Scrubs, I literally show up, I'm the primary person to do this campaign. I'm about to go on set, and I was like, let me go use the restroom. I was in New Jersey, I was in a building that was built in 21. So I show up, and none of the bathrooms in the building or the adjacent buildings are accessible. And then someone comes up to me, well, can we lift you up to the bathroom? Can we help you somehow? No, find me a bathroom that's accessible. Find me a bathroom that I can keep my dignity and use and not feel like I am now inhumane because a simple need, like a bathroom, is not available. How does that affect your patients, your students, anyone and everyone? You no longer feel like you're a human being when your basics can't be met. That's Maslow's. That's the first thing we learn. And then the second thing we learn is don't do any harm. But how much harm do we do every day just not understanding disability and how it shows up for other people, whether it be visible or invisible, and then how does that impact their day-to-day lives, showing up in front of you, getting there? We all know that people have socioeconomic problems. Add disability tax to that, and it's even worse. Because someone may not have the cab money to show up for a doctor's office visit or whatever the case is, but someone might have the money but still can't even get a cab because it's not accessible. Okay, so now we're thinking about the bus and the transit systems. Where do you live? Like, this is where it's so important to vote and show up for census and to talk about this with your patients and talk about this with your peers, talk about this with your colleagues, talk about it with everyone. Because funding for disability comes when nurses talk, okay? And because guess what? Everything that you're advocating for in your nursing shows up in your patients' lives. And usually what we're advocating for is those of us with disabilities is going to show up and make your workplaces better, because that's what the ADA did. However, the ADA is ancient, and it's the bottom of the barrel of what we need to meet, and we can't even meet that. We don't even understand it. We don't even open the book and learn and say, this is what we can do, or this is what we can implement right now. Instead, we just think that this is a law that's there, and it should be there to protect. And like Sabrina said, usually when we're filing a complaint, it's because of privilege. But let's also remember, if we're filing a complaint in healthcare, you're blackballing yourself, but opening the door for the next person. So I can, thank you. I can literally file any complaint. Why didn't you file complaints when you were getting rejected? Why didn't you file complaints against your nursing school? Because that would have blackballed me. That would have said that I would not be sitting here in front of you all today. It would have said that my nursing career ended the moment I rolled into orientation. Okay, so this is where we have to say that we're going to do better and understand people where they are meeting us and where we're meeting them. Because if they're asking for something, trust and believe, we know that some students can ask for the moon, okay? And the moon is not acceptable to ask for, but at the same time, why not? Why not? At the same time, why not? Who gets to decide that yes and who gets to decide that no? The only reason why I can say that I'm actually sitting here is because I've always had answered to my own yes. No one else is going to tell me what my disability can and cannot do. That is for me to tell you, right? So if you give me the opportunity to tell you, then we can definitely work together and make magic. But if you already close the door, the student's not going to learn, student's not going to pass that board, student's not going to go through 76 interviews, student's not going to learn how to navigate disability for someone that's going to come behind her. Forget nursing for 1 second, just in disability. Again, if representation isn't there, how can we be? We talk about that just being the color that we are. We talk about that being the gender that we are. We talk about that in any of the identities that we pick, but when it comes to disability, whether invisible or visible, we shun it because mortality is now in front of our faces. And remember, the moment we leave our homes, even in our homes, disability can happen.
Okay, you just touched on so many important things, and I wish I had a notepad so I could respond to them. So one thing you mentioned was like disability tax, crib tax. So like the government does not design society to accommodate for disabled people and then expect disabled people to pay to make it accessible for them. So like the disability tax is so real. Like ordering groceries, not being able to take the train like other people are able to because it could cause pain, or lifting stuff can be a problem. Like it's having to Uber and like all of these things that add up and get really expensive. Having to buy a certain apartment because you need a dishwasher because your screws will stick out if you don't have a dishwasher, or like all of these things that add up in society. And then the other thing is like the pathologizing certain disability. So like within nursing education, now there's like a bigger push to accommodate for people with learning disabilities, and then people with physical disabilities are just like left out and pushed out, like, oh yeah, we can accommodate for learning disabilities. Well, I don't have one. And then you mention a physical disability and it's just like, oh my God, there's no way we could accommodate for that. And it's just because it's normalized within higher education to accommodate beyond clinical settings in the didactic setting. And that's it just has to do with how much energy is being invested in making things more equitable for people with physical disabilities.
So what are 2 action items that you think we can give our crew? Just right off the bat, like what are 2 things that...
Okay. Number 1, trust disabled people. We're not asking for things that we don't need. I'm gonna make it 3 things.
Okay.
Number 2,
be creative. Like, you have to be creative with disability. We're creative nonstop because we cannot navigate society without being creative and figuring out how to navigate a society that is not designed for us. Non-disabled people need to get better at working on the creativity, and that's something that disabled people offer to the healthcare workforce. Is nurses are constantly adapting when they don't have the tools and supplies that they need. And so disabled people, we do it nonstop, not just in nursing care. It's like when we're navigating society, we're constantly creating and adapting to our bodies. Third thing I would say is improve flexibility. Like, be flexible with, like, there's this idea that everything, and it's so big in nursing, where everything needs to be done a certain way. There's these exact steps. If you move your hand slightly this way or this way, then you did it wrong. And we can do the exact same thing with the exact same safety precautions with doing things differently. Like, that's what we do nonstop, navigating society. So, yeah.
Adaptability and flexibility is what I heard.
Yes.
Like, that is
There you
one
go.
of the key traits for anyone that has acquired or had their disability from birth. Like, this flexibility and adaptability comes along with these individuals, like, automatically built in. And then when you add nursing knowledge on top of that, or any type of healthcare knowledge on top of that, we automatically know how to switch on a fly, right? Like, we know how to deal with all the things that could possibly come up. So for me, in healthcare, let's see, the first thing I'm gonna ask you guys to do is look over your syllabus. Stop directing students to just go to their disability office. Let them feel comfortable to come and speak to you. Particularly, they don't have to disclose anything. Just like if you're meeting a barrier in my discourse, please come and speak to me so that we can figure out how to help you navigate that barrier. It's just an open dialogue. You're allowing someone to feel trusted with you, and if they feel so trusted to disclose a disability, say thank you for telling me. Would you like to continue discussing, or would you like to just tell me whatever barriers it is that you're facing? Because now you're allowing for that person to personally decide how much trust they want to put into you without feeling like they're going to be turned away, without feeling like it's going to be used against them. I currently mentor students that are going from high school STEM programs into healthcare or STEM and higher education. I can't tell you how many times I get an email, up to last night, where I'm getting told that they're being held to a technical standard. So I'm gonna ask you guys on my second thing to understand the difference between technical standards and a job description. Because technical standards do not hold someone's hand to the fire, whether in a job position or at school. Technical standards is what we're asking you to be able to meet in order to do the job, but we know nursing is not just in a clinical setting. And if our profession cannot expand past thinking about clinical standards or technical standards, then we're gonna definitely lose our workforce. Because we know that the silver tsunami is upon us, where our nurses are gonna be retiring out and we do not have the replacement. And COVID was a mass disabling event. There are people dealing with long COVID today where it's not apparent disability. This is something that they're asking for, and if we do not know how to have the conversation, just by accepting and understanding our own biases, we're gonna continue to close that door. And we're not gonna advance.
Yes, there are so many pathways within nursing that if we block people out at the BSN level, like there's so many inherently accommodating pathways within nursing. There's telehealth, informatics, administrative, PhD, NP, DNP that can inherently accommodate. And then also not keeping people out of clinical setting if that's what they want to do, like figuring out how to make it work. But yeah, we can't be keeping people out that early. But yeah.
So we're gonna wrap this up, and I'm gonna say one last thing is that, if we can change this for ourselves and the understanding for ourselves, being in the positions that we're in right now, we'll be able to change it for our patients, and we'll be able to change it for our students coming in after us, because the narrative has shifted. So my call to action for today is to make sure that you guys shift the narrative.
I'm going to close us out with a poem.
Okay, so this one's on my experience with ableism in undergrad nursing education, and it's a crib critique on the future of work. And I want to give a shout out to Arizona State University for funding this poem, and yeah, Lincoln Center of Applied Ethics. Okay, all right. I'm coming out. No, this poem is not what you think it's about. Okay, so I took a year off after the 12-level revision spinal fusion, and switching gears to choosing a career, a couple things went into my conclusion. Firstly, personally living through the patient experience, everything from post-anesthesia confusion to learning that despite what society says, acquiring disability does not mean my life is ruined. Secondly, having been influenced by my nurses' care contribution, my trust in them as healers, as some of the most dope humans. Thirdly, internalizing that the medical industrial complex demands a radical healthcare revolution, I decided to pursue nursing without realizing I'd face traumatizing, disability-based exclusion, disillusioned nursing. We must do better as a profession, as an institution. So this is what happened. I studied nonstop for this really competitive nursing program, right? I make it in, nursing classes begin, and at the bottom of every syllabus, it asks us to come forward if we have a disability. And realistically, I just needed help lifting patients up in bed and an accessible seat, but after coming out to my clinical instructor, because of bureaucratic infrastructure, I was passed over to the course head who blatantly asked me why I would enter a major I was not capable of participating in physically. She handed me a list of technical standards, which was this long list of abilities that collectively would comprise the most normative, abled body, and the course head legitimately said, you can't be here if there's anything on this list you can't do. Essentially, a gatekeeper saying, good luck getting through. She asked me, quote unquote, what's next? You can't even lift an IV bag? Which was insulting and untrue. That course head made it clear that disability was not to be included in efforts of recruitment, that disability was viewed as nothing more than a nuisance, a nursing pollutant, that it'd be easier for everyone if I were just a truant. And as a racialized, disabled undergrad student, I can't articulate how powerless I felt sitting one-on-one with her in that room, being punished for an identity I had no control over. I had to hold back tears and wear strength as a costume. No fair. You really know how to make me cry. I'm scared. Scared that someone in a powerful position already made up her decision, call it forced attrition, scared that I just spent over $10,000 in tuition to complete a very specific set of prerequisite courses for a major that rejects my body-mind due to the ableist policies it enforces, fails to systematically question, and thus endorses. I was next offered a medical leave of absence by an administrator, as if suggesting I temporarily leave for a permanent disability made her some kind of innovator, equity illustrator. Minutes later, she said, you need a letter from your second surgeon granting permission for you to stay in the program. As if the person who knew my abilities better than me was this non-disabled white man, and my second surgeon was amazing, worthy of praising, and he said, of course you can do nursing. There are doctors in wheelchairs in case the administration needs some affirming, and you don't even want to do bedside, so your BSN shouldn't be deterring. He wrote the note, and my college brushed it under the rug like it never happened. I registered with disability services who were even more uninformed on clinical accommodations than I could have imagined. I'm sorry, but I did not need or use extra time on examinations. Not being offered accommodations had painful implications. After clinicals, I would have to lay down for hours, heating pads, hot showers, and additionally, ableism itself was disabling. The stress from potentially being dismissed because of my disability was unwavering. My connective tissue and endocrine disorders flared. Yes, ableism made me more impaired. My muscles were twitching. A nerve issue triggered full body itching. And you know what I lost? So much hair. There are physical repercussions to constantly being subconsciously scared. We need to do better as a profession that claims trust and care. Dear institutions, you break trust when you punish us for confiding.
creates safety and silence and hiding. When an institution abandons a disabled person who is most often labeled the burden, deficit actually rests in institutions that fail to generate innovative solutions didactically or clinically. What if workplaces resisted politics of disposability, went beyond accommodations to address how unjust labor conditions produce disability mentally and physically? CRIP lived experiences can transform academia and industry. They can teach us how to make disability more livable. Our survival is critical, and also teach us how to design communities and spaces, identify opportunities for changes so we do not unjustly manufacture impairment. Let me be transparent. We must demand flexibility, fill institutional gaps through access, intimacy, cross-identity, solidarity, learn to trust radically, like, excuse me, but people only use accommodations they need, actually. I've got to show the world all I want to be, all my abilities. Somehow I'll have to make them. Just understand I got it well in hand, and oh, how I have planned. Despite gatekeepers who exclude and reprimand, disabled people will always have more expertise about our own needs and capacities than any doctor, boss, or faculty, and one day, disability shaming will cease, so that instead of coming out, we can just be.
I'm done. I'm ready to go. You guys have questions for us? Let's take it.
This is what I woke up for.
Oh, thank you.
Amazing. Let me tell you, I have a disability. Yay. And I don't tell my organization because I will be eliminated. I'm a mom of 2 boys with autism. I work with the SCN, SCI patients over 30 years, wheelchair-bound women. Couldn't get access to mammograms because in a wheelchair. No accommodations. I'm at work one day and I got a phone call from my husband that my son was assaulted for passing gas. He was thrown against a wall, and just what I felt was rage because no one protected him. What you women went through is a testimony of survival. And in nursing, we have to back each other up. When I have my students and they have a disability, I work with them one-on-one because I want them to succeed. Don't stop what you're doing because you women are amazing. Amazing.
Thank you. Thank you.
Hello, ladies. I do not have a question. I just want to tell you, you two are awesome. You're right up my alley when I talk about bias. I don't know if you heard what I was talking about with black women, but you two, it's just, I tell you, did my heart good. And the thing is that we need to spread the word, and it needs to be in all educational systems. It needs to be in medical schools, nursing schools. Y'all need to travel the country and just spread this. This is amazing.
Your lips to God's ears, okay? Just put it out there for us. We'll be at an institution near you soon.
Good morning. My name is Dr. Courtney Pladson. Thank you both so much. This was so action-packed. I feel like this could have been an entire day. There was so much here. I also just want to acknowledge your lived experience leadership. It is a really beautiful way that you have weaved the ways in which your personal and professional expertise are give you a unique skill set to lead. So thank you for bringing all of that talent and sharing that with us today.
Thank you.
I do have a question, especially for you, Dr. Jamal-Eddine. You mentioned a thread about disability justice, and you talked about intersectionality. You mentioned intersections of being a woman, a person of color, a person with a disability, and being a nurse. And when I think of intersectional movement building, we can't separate disability justice from gender justice, racial justice, environmental justice. I'd love to hear from you both how we in this room of leaders can really work towards collective liberation? How do we bring all of this movement building and work together? Thank you.
Thank you. That's a super good question. There are a lot of resources on like the intersection between ableism and racism and the history within the U.S. The way that like antebellum doctors, if you start reading about basically antebellum doctors created the construct of race to oppress people of color, and they did so by saying that people of color are inherently deficient, lacking, unwhole, disabled. So they used ableism to justify racism, and when you look at the intersection between the two, and then that's saying like that inherently disabled people are unwhole, deficient, or lacking, and that's the medical model of disability, which is still the norm within healthcare, that disabled people are deficient, lacking, or unwhole. So while healthcare superficially has said that they view people of color as no longer unwhole, deficient, or lacking, it's still rooted in ableism, and it's still used against disabled people, and it's still used against people of color too, because in practice it hasn't been fixed clearly. So yeah.
Well, yeah, just look at the Patient Bill of Rights. If we just look at that overall, you realize that there's no disability language there, and it's all ableist in how we are asking patients to show up. So if the Bill of Rights is justifying how a patient shows up, and it doesn't have the inclusive language, you're already excluding them, right? So this will transcend, the Patient Bill of Rights transcends education and clinical or acute care practice. It is what everyone is held to, whether you're a nurse in any gender. So if we don't change that Bill of Right just in healthcare, we're automatically at a setback. So for everyone in this room, even when you're setting up a new practice, understand what that Bill of Rights actually looks like for your patients coming in, for your students coming in. Whoever is showing up in the moment is what we want to address based on how we're giving them the information. The information's already there, so now it's our turn to change it. Again, changing the narrative.
Yeah. Real quick, just overall, take advantage of the resources that do take an intersectional approach to it, because they're out there. And when you're studying racism, like Andrea said during the talk, include disability. Like this, it's left out of studies because it takes extra work to include disabled people in your studies. Put the extra work in. Include disabled people.
Wow. Hi, my name is Madeline Feliciano-Weiser. I'm a DMP candidate. This is the first conference that I've gone to and listened to a panel or presentation in which I've taken notes to take back with me. And what I heard is that as a profession, we need to look at the world around us through a different lens. I helped open up a new facility. You dated a building in 2021. I opened up a new facility in 2022, and as I was reflecting on what you were saying, we have beds that don't lower. So the ED is not accessible, right? So we want people to transfer into our gurneys, but our gurneys are up here. There's no way to transfer. And then the dignity piece. Let's lift you onto the gurney. That's not respecting the person or meeting them where they are. Entrances, the back door entrances, yes, that's an actuality. Parking spaces, I don't know if you guys know this, but buildings are required to have certain accessible parking spaces, and there's measurements. So it brings me back to the ADA. Why do I know all this stuff? For those of you that don't know, my husband is a T2 paraplegic, so this is my world. So if you tell someone, oh, go file a lawsuit, that burden is on the person filing the lawsuit, and they have to go through the Department of Justice as a plaintiff. And something that we are living right now, my husband and I, in the state of Pennsylvania, is that there's no one in the state of Pennsylvania, there's no attorney in the state of Pennsylvania who will take on a disability.
No attorney on the whole East Coast.
No attorney on the whole East Coast. We're actually speaking to someone in California. You probably know his name. There's also issues with housing, as you said. One of the things that I challenge my colleagues to do, look through a different lens, and two, for lack of a better way of saying it, keep your mouth shut. I can't tell you how many times my husband has come to visit me at work in his wheelchair, and people, my colleagues who don't know who he is, have looked at him and said, oh, you're going home? And he's like, every single day.
Thank you.
Oh, wow. This has been an eye-opening presentation. I echo what everybody has said. As a future nurse educator, because I just graduated. My name is Sabrina Baba. I just graduated with my DNP from Hopkins, and I'm excited to start practice. But this has opened my eyes, so when I see people and somebody tells me they are disabled, to believe them and not have to have them prove that they're disabled. I went through a recent experience where I was at the gym trying to be fit and injured my back. And it really was eye-opening for me because I couldn't even tie my shoelace. And I started thinking, I'm like, wow, think about my patients who come in and say they're in severe back pain and they can't do this and they can't do that, and I'm in this position. And I started having some fears, like I'm about to start a new practice and I have this back pain. Am I going to go and say I can bend to auscultate my patient's heart? And there was so much fear and thinking about myself as a person of color. How can I go to this job where I'm going to be no person of color, telling them, oh, my back is hurting? And I started going frantically to my primary care provider, going for physical therapy because of just this fear. And I'm thinking about what you shared about your lived experience. And I always try to ask myself, what can I learn from this? And one of the things I learned from it was have empathy for people. And you sharing what you shared and what you went through in nursing school, as a future educator, I want to take that with me and be able to advocate for students who are disabled when other faculty members are using ableism, to be able to say, no, let's give this person a chance. So thank you so much. This is something I want to take with me and advocate wherever I go. So thank you, thank you, thank you.
Thank you.
Thank you. Yes, the moral of that is like trusting patients, because once you have a disability experience, you can.
We're
We
the
were talking
master
about
of
that
it.
last night.
Yeah,
Yeah,
we're the master of
trust
it.
people.
Yeah. First of all, thank you both for your presentation. Andrea, I just want to say something to you.
Okay.
I don't want you to
About to
give
be-
up your dream of becoming a CRNA. The only reason why I'm saying this, I'm Dr. Lena Gould.
I know exactly. She did not need to. There was no introduction needed for Dr. Gall. I knew who you were when I was in nursing school. Go ahead.
I'm the founder of Diversity Nurse Anesthesia Mentorship Program. 8 years ago, Dr. John O'Donnell at University of Pittsburgh accepted a student that had a prosthesis, arm and hand prosthesis. That was very difficult for the very first time in history that someone accepted him. Now, that same CRNA is a chief CRNA and a clinical coordinator. Andrea, for the past couple of years, I've always had diversity CRNA events at the University of Pittsburgh. I'm inviting you next year.
I'm coming. I'm in there.
And I want to introduce you to Dr. John O'Donnell.
I'm with
I want to introduce you to the other program directors that are going to be there. One of them will be Rush University, who believes in admission equity. I will personally mentor you. I'm going to make it happen. We'll
Thank you.
exchange information before the end of the day. Okay?
Thank you. Thank you.
I love the magic. Thank you. I know we're running out of time,
Right.
but I'm going to follow Dr. Gold and invite you onto my platform. I'm the executive director for the Center of Nursing Workforce in Connecticut, and I need you to be guests at a lunch and learn to share within my state, and that's just the first stop, because we're going to get you with the ANA, we're going to get you with National Association of Hispanic Nurses, the National Black Nursing Association. Your stories need to be out there. Your power needs to be out there. So thank you for what you do. Network. We got work to do. Let's go.
Thank you.
Thank you.
Thank you. Group hug.
I gotta say something though. Hey yo, so I gotta give a shout out to Dr. Anna Valdez. She has taught me so much, and I'm so grateful for her. She's brought tremendous value to us as docs and to me as an individual. Because I'm always putting her to work, but she's like, how can I be of service? And I was like, I want to elevate voices of disabled people. How can I do that? Because I was thinking about conferencing and just her sharing her journey with me and teaching me so much. I've become so acutely aware of the experience of disabled people. And I've been going on conferences and I've just been cringing like, oh my God, like I just went to a conference in Boston at the convention centers and I'm like, I'm winded trying to get to a session. It's just like, and so I'm like, Anna, you have to help me. And poor winter, we were looking at different venues and the Franklin Institute, I've been haggling. I was like, I need to make sure that it is accessible, and I need to know what that means. Send me a map. We need a path of travel. I'm on FaceTime with Anna, like, okay, so I'm in the museum. All right, where do I need to go? And she's like, okay. And so we've had so many conversations, and I've just been so acutely aware, and I just thank you all for your advocacy. I thank Anna for her advocacy and calling me out, like, you being real ableist right now. And I'm like, oh my God, like, thank you. And so I'm so glad that this session is given what it was supposed to give in the spirit that I was hoping that it would come. Thank you, Dr. Gould, for just coming in with the gold pinky ring. But this is the energy that I wanted because I want your voices to be included here. And so we've been also looking to partner with NON, and they gave us a lot of feedback. And so we're going to bring back like the virtual part of the conference because they again shared another lens. I'm like, oh my God, yeah, I forgot about finances and then just getting here and being part of, so I just want to thank you and then also just elevate Dr. Anna Valdez's name and her life and her contributions to all the things because I just wanted to just highlight my sister and just thank you all for being present and allowing us to have this opportunity to share. So thank you. Thank you.